everybody could see it. All right. Well, we'll go ahead and get started. I want to thank everybody for joining us today for one of our CIDMI presentations, and we're really excited to have Dr. Salil Soman, who is a relatively new associate professor here in the Department of Radiology and Biomedical Imaging. He joined our faculty last year, and before he came to UCSF, he was at the Harvard Medical School and the Beth Israel Deaconess Medical Center, and was co-lead of something called the Functional Neuroimaging Service. He is a neuroradiologist, but has an undergraduate degree in chemistry. Yeah, fantastic. And public health. We know these all mix very, very well. Did his MD at Rutgers, and even has a master's in computer science, and that was probably in the days before AI, right? Anyway, we're really excited that he's going to be talking to us today about susceptibility-based neuroimaging. I believe this is MR, correct? And today's practice, tomorrow's potential, and also talk to us a little bit about how this may be applied in infectious disease. So
awesome.
Soman, thank you so much.
Thank you much. All right, cool. Well, thank you for the opportunity to speak. It's so nice to be here. So yes, as you said, I'm a neuroradiologist. So I have tried to set up this talk to be geared more towards a broader audience, but at any point, please feel free to interrupt. But we'll definitely do questions at the end as well. Okay, so with that, I've got no relevant disclosures. And so hopefully people can appreciate that these images all look different despite being of the brain. They do have an underlying commonality, though, that so when you may have heard of T2 for MRI, there's this other feature called T2 star, which is what all these images draw from. So with that sort of background, we're going to cover some basics of susceptibility imaging. Just want to make sure. Can people see the cursor?
Yes.
Oh, okay.
Yeah.
Oh, okay.
Yes. Yeah.
Great. All right. So we'll talk about things that SWI and QSM are some of the more common versions. We'll talk about a bunch of clinical applications, then some future directions. Okay, so with that, we'll just start with what is tissue susceptibility, right? And so the idea is that, there's a symbol chi. It's the degree to which a material can be magnetized by an external magnetic field, right? And so MRIs are big magnets, and so separate from all the tricks that we do to make our images, there's the individual pieces of tissue can deform the field and give us more information. And there's other features about it being a proportionality constant. But it's dependent on the molecular constituents of what you're actually imaging. So, which again, for this group, I think there's all kinds of opportunities for looking at how the susceptibility in inflammatory cells, in different kinds of infectious processes will change. And so that could actually help with disease tracking, therapies, et cetera. And so for the major things in susceptibility, water, myelin, iron, calcium are the things that we most care about. But there are other items as well we'll talk about a little bit later. All right, so for susceptibility, we talk about things as being diamagnetic or paramagnetic, and it's really trying to reflect the electron state, whether you have paired or unpaired electrons for the molecules that you care about. In terms of susceptibility, you have positive things that are paramagnetic, right? And so, but really the big ones are blood products, gadolinium. There's a number of others. Then you can have diamagnetic things, which are going to be negative susceptibility. And there's water, phospholipids, most organic molecules, but really calcium is the big one that we end up trying to distinguish, right? So in terms of imaging types for, those, when you're looking at MR, there's a lot of different names that clinically you'll end up seeing susceptibility. You might see SWAN, SWI, Venibold, uncannon, there's FSEB, and this is definitely not exhaustive. There's a lot of different other types as well. I just want to walk people through sort of some things that they may have seen so that you can connect what you know with where we're gonna go. Because this talk is definitely meant to start out at common knowledge, but then we'll go into what I think is the future and stuff that I think is exciting. Okay, so in some other examples, so from GE, there's this product called SWAN. From Siemens, there's something called SWI. And those are the main images that you'll see, but from them, you'll often see derived this, Philips has this SWIP, or Venibold, and there's others, but these are some imaging examples that you'd also see, right? But that being said, for any of these kind of susceptibility images that you'll see, separate from these magnitude images that you have here, right? they'll often will be these maximum intensity projection images where you see all the veins just sort of, more pronounced. And then there's this thing called the filtered phase map, right? And so here, for susceptibility, we talked about positive or negative. So when you're looking at these magnitude images, all of that info, positive, negative, goes away. But the filtered phase map is supposed to help you get some of that back. And as we'll talk about later, like it's a way you could use this to distinguish blood from calcium, right? Or other like paramagnetic from diamagnetic things. All right, so just an extension of this that is becoming more clinically available. And since I've come here last summer, we can do this imaging on anybody on any of our 3T scanners across UCSF, quantitative susceptibility mapping, which is basically it's an extension of what the SWI imaging does, but at the same time here the values are actually quantitative. You can draw little circles on it and get real values back. Things that are positive are going to be bright, things that are negative will be dark. So you can actually use them quantitatively. But I want to show you that there's a lot of different flavors. When people say QSM, these are just 3 that my lab published on before I came here, right? For this MEDI, the MCTFI, and total field inversion. And then there's dozens of others, right? And so just some more examples in case you felt like I slided some other version of QSM that you like. Okay, but now, come on, here we go. One thing about quantitative susceptibility mapping, though, is that what you're seeing in there is that at every voxel, there is going to be some net paramagnetic and diamagnetic signal, right? Because you're constrained by how you got to pick a spatial resolution. And whatever you pick, it's going to be a net value that you've got in there in each box. Again, this is going to come up important later, but just wanted to give you that sort of idea that just because it's quantitative, it doesn't mean that it's definitely calcium or it's definitely iron, but it's more that there's a mix, and then we're trying to figure out clinically what's going on. Okay, so one of the challenges with SWI that I'm sure most clinicians that on the call have dealt with is like, okay, well, if you're trying to figure out blood or calcium and you're looking at the filtered phase maps, that's these images you're seeing here. I'll tell you, this is the exact same person, exact same scan data, but it's made in these 2 different ways. And you can see that, the vein here looks bright on this one and it's dark on this one, right? And so coming back to it, the idea is that the vendors, depending on who made it, they're going to end up, they have what they call handedness, right? So basically, when for Siemens and Canon, for these left-handed systems, blood's going to be bright, calcium will be dark. And for GE, Philips, United Imaging, others, it's right-handed, so it's a reverse. But for me, my rule of thumb is find a vein that you think is normal, right? So long as you can find some vein that you think is normal, definitely not thrombosed, then you can look at that and go, okay, well, if it's bright, then blood is going to be bright. Like, so if it's a cerebral microbleed or then whatever, then that's what I'm going to follow, or vice versa. And so carrying that on to this example here, right? So now you can see that this is a left-handed system where the vein is bright. And so you know that this bright dot here is blood, not calcium, which goes with a microbleed. Whereas here on this right-handed system, the vein's dark, right? And then you've got the dark signal. So again, so long as you follow the vein, you can figure out the filter.
So I didn't realize, so the different platforms, it just depends on which hand, is that right? So
yeah.
I didn't realize, okay. So,
yeah. I mean, it's one of the reasons I like QSM, but I will say that there are some limitations with QSM is the reason why we, by default, still stick with SWI. All right, cool. So anyway, all right. So other techniques for susceptibility, there's something called ultra short TE imaging, right? Where I mean, again, hopefully to the clinicians in the audience, like this looks like CT, right? But this is all obtained. It's obtained from a kind of MRI acquisition, and then you can reconstruct it in different ways to make it actually look like bone. And so GE has a package called OzTO that we can run on, acquire on some scanners. There's a bunch of different others. And so, I mean, like, here's another one, the synthetic CT one, where they're doing is for T1 weighted acquisition, but so this is the real MR, this is the real CT, and this is the synthetic CT they were able to make off of from the MR acquisition. So, I mean, there are ways, if for some reason you can't get somebody to go do a CT, or you don't want to do ionizing radiation or what have you, there are ways to get it out of the MRI session as well. All right, so and just to be fair, like, there's a bunch of, and this is definitely not exhaustive, but there's a bunch of other susceptibility techniques that I'm just not going to cover, like dynamic susceptibility contrast and fold that we use for fMRI, or using ferriheme or other injectables. Like there's a broad area of places to go that I'm not going to touch in this. So here I'm just going to touch on just because you order an SWI or a QSM, you potentially, depending on where it comes from, could get very different images. And so that's what I wanted to show here. I mean, basically things to think about when you're comparing studies. So, I mean, certainly I've encountered clinicians who have said, oh, well, the GRE looks, or SWI, the signal looks much bigger. And it's like, well, one was at different field strengths or different scan parameters. And so again, that's just what I want to touch on here. Right. So here, right, the echo time, right. So going from left to right, you've got increasing echo time happening, right. And so in general, what you can see is that the more, as your echo time goes up, you get more T2 star, like more blood / calcium weighting, right? But you also get, though, is some more distortion. I mean, here it's not looking horrible, but in other planes, it can be much more pronounced, right? For flip angle, right? So the lower your flip angle, the more T2 star weighting that you get. So hopefully you can appreciate this is exact same person, exact same sequence, but we just changed this one parameter and you get an image like this versus an image like this. They look quite different, right? Then a TR is another one, right? So the higher your TR or repetition time, the more sort of susceptibility kind of signal you get out here. So here, like all the way here, you really can't tell the difference between gray and white matter. But here, the white matter tracks are really just jumping out, right? So again, that's just more susceptibility. So the myelin and the white matter tracks help you sort of see the difference. Okay, so, and to show you some practical examples, so I mean, the one that I know the most is like being involved with the anti-amyloid therapy group here in neurology. But, so cerebral microbleeds are something people care about. It's basically it's one of these complications that it may prevent people from getting anti-amyloid therapy, or once they're on it, it may make them stop getting it because it's considered a complication. But a microbleed is like basically you've got these big bleeds, right? These you can see it on CT, you can see it on the MRI, but then there's these smaller bleeds, these little dots here, which you really can't see on the CT, but on the MR we can see as these dark spots, right? And so again, they have the clinical implications I talked about. When I first started doing this work, actually one hurdle I was sort of dealing with is that some of the literature was actually published as microhemorrhages instead of microbleeds. And then, so again, apologies if there's microhemorrhage people here who don't like that microbleed.
You like microbleed, is that right?
Well, that seemed to be where more of the papers were published.
Okay.
That's what it was.
Yeah.
So anyway, but to give you some examples of how the imaging can actually lead to variability, right? So as we talked about with microbleed, you don't invisible on CT, but you can see it on this 2D GRE MRI. But then here's an example where I've got a 2D GRE, right? So basically 2D and 3D are different ways of doing MRI acquisitions of the brain, right? And so with the 3D acquisition, not only you can see the yellow circle on both of them, but then if you look at these red circles on the 2D GRE, it's pretty much invisible, whereas you can see more microbleeds on the 3D GRE. And I mean, while it may sound sort of like, sort of academic, literally the difference between the scan on the left and the scan on the right is that the one on the right, like if you call that 4 microbleeds and there's one more somewhere else, they would have not gotten anti-amyloid therapy. They'd be the cut. Whereas if that same person got a 2D GRE, they would have been fine and probably would have gotten the therapy, right? So anyway, it's the implications of the physics that I wanted to point out. Same thing here with a 3D GRE versus SWI. You can see the yellow circles on both, right? But then there's this one in the lower left, the red with the arrow down here. That you could around here, right, where you can see that it's just you can call an extra microbleed off. Then the slice thickness, right? Whether I do thick 2D GRE versus thin, again we can see microbleeds on the yellow circles on both, but the red here, I mean, it's the lighting. Hopefully online people can see this a bit better, but basically there's more microbleeds you would call on the thin. Similarly, using thin 2D GRE versus SWI, you've got some areas that you can see on both, but then others that you can only see of siderosis, which again would be a reason, calling one area of siderosis is enough to not be able to give somebody anti-amyloid therapy, right? So depending on how you image, we would get a different answer. And similarly, like, the field strength, right? So 1.5 versus 3T, there's some microbleeds you'll see on both. There's others where so in the circle on the left here, there's one dot that I think you would see in both. There's a second one that I don't think I would be able to call on the 1.5 acquisition. Right, and then here, this is a ventriculostomy catheter tract. And if someone was asking me, hey, does it look like that there was any blood along there? If I had this image at the lower echo time, I might say no. I see this higher one where it's all dark along the tract, I might say yes. Right, so again, clinical implications of variations in acquisition.
So
please, yeah.
So it looks like field strength matters here.
Oh yeah, right, for SWI.
For SWI.
Right, yes, right. And so I mean, we'll get into other applications, like other ways around it, but that is what sort of put me into being interested in QSM, right? Because the idea is it's a quantitative susceptibility map,
Okay.
right? I mean, the issue there though is that how you sample matters, right? I mean, so the echo times that you have to sample over at 1.5 Tesla are different than what you would do at 3 or at 7. And so, but still, you can get kind of similar maps, right? So, and I'll have some examples at 7T to show for that also. Okay, so getting into some clinical applications just so people are lost. So PML, certainly something that you all are concerned about. Here, and here's an example where you can you can see the flare kind of signal abnormality here, and there's a QSM signal that's going along with it, right? And so whether that's related to activated macrophages or something else, that pathophysiology still been worked out, but that's part of why I wanted to make sure that we had the ability to do this if we wanted to here now, right? Similarly, so here's more PML examples from the same paper, but again, just sort of some flare signal abnormality that that all the way over here, then again on the susceptibility imaging you can see, and then also some the venous changes as well.
I wonder if that would help too, because a lot of the time with PML, we have a real hard time with, is this lymphoma?
Right,
versus, because it's going to be the same risk factor in these people with no CD4s, basically. So I'm just curious, this could help kind of differentiate, because that's often on the clinical side, we can't, we're trying to figure out, because the treatments are very different, and,
for sure,
and try's to avoid brain biopsy up these things.
I mean that's exactly what I'm trying to do, and I will say that there's very limited literature on these sort of advanced susceptibility techniques looking at PML versus other etiologies. So again, I think it's an open area for us to be able to look at more. So it's more examples, and then long COVID. So this one. So I'm going to talk about this more later. Oxygen extraction fraction mapping is an area that I'm particularly excited about. And so in this cohort of people who had long COVID versus people who didn't, basically they found that you could use oxygen extraction fraction mapping methods to distinguish between them. But they were using actually a technique that only, I think it was JAS or something that basically looks at the vein, the superior sagittal sinus as a proxy for the whole brain. Whereas the methods that I'm more excited by, and that I'll show you later in the talk, actually give you like a pixel by pixel layout of the whole brain, right? And so anyway, but this is just to show you that people have already done some of this stuff and that there's room for us to look at this more. Okay, and then getting to some other just sort of bread and butter applications, right? So venous thrombus here, we've got a T2 image where this is a little bit dark here, right? So this is where you would see like the transverse sinus, like so this is the back of the skull, and there's the transverse sinus there, and you can see on this 2D GRE that there's asymmetrically dark signal, which you could ask, okay, well, could that be bone volume averaging or something? But then here we have post contrast where you can actually see there's contrast going around a thrombus that's actually in the transverse sinus, right? And then the applications I was talking about for anti-amyloid therapy, right? So this is the criteria for deciding on the follow-ups after somebody's been started anti-amyloid therapy, if they have new areas of microbleeds or siderosis, how you decide whether or not to, mild, moderate, or severe means whether or not you're going to continue the therapy, hold the therapy, or keep going. And then hemorrhage, I mean, certainly this is work that my group's done a bunch in, but so here is a non-contrast head CT, and you can see this subdural here. I mean, it's a little like, this is just normal dura, and it's, but you can tell that it's a little bit thicker here, and you can certainly see intraventricular hemorrhage on the CT. But then here's the SWI. Maybe you would call this asymmetric, but again, depending on the tilt, that could be just volume averaging. Again, you can't see the blood in the ventricle though. On the SWAN, right, and that's why I wanted to bring up that there's different versions of susceptibility also. Right? On the SWAN, I'm not sure that I would call anything off of this. I mean, certainly the IVH I would call, but the dural stuff, it looks pretty symmetric. And this sort of gets at this. The SWI is really trying to make differences in susceptibility pop, whereas SWAN is trying to do contrast and noise, give you a prettier picture, but ultimately there's a cost, right? And then for QSM here, you can see there's this big puddle of bright, right? And so again, it makes there's clinical applications that this susceptibility mapping can help you sort of leverage. So here's an arteriovenous malformation. With these things, one of the things people care about is that has it bled? If it's had a history of bleeding, then they're more likely to intervene than not. Here's on a non-contrast head CT, you see a bit of bright here, which even without blood, an AVM can have. Where SWI, you see areas of dark and some areas of bright, but again, you'd have to look at the filtered phase map to try and decide, is this blood or not? And there's issues with that I'll show you on later slides. Same thing with SWAN. QSM, it's all bright. That's blood, period. And so,
I have a question. I don't do like imaging at all in my work, so this is like a really, really basic question. But so for all these different methods, you need different instruments and.
Oh no, gosh, that's a great question. Okay, so non-contrast head CT, right? That is one kind of machine, right?
Okay.
All of these ones, all three of these images, right? It's all from the same scan.
Okay.
On this MRI scanner, you scan them once. That raw data, so long as you have the raw data, you can make all these different things.
So as a clinician, you could choose.
Yeah, well,
based on the machines you have access to, but you wouldn't need to have 10 different machines to
right,
get all these.
Exactly right. Yeah, right. Yes.
Thanks.
Oh no, that's a great question. Yeah, I apologize. It's thank you. So getting at the blood versus calcification issue, right? So when everything works according to the textbooks, right? Here's a non-contrast head CT, and I'll tell you this is a calcification in the core, right? So that's what you normally would expect. Very common thing to see. Here's an SWI image where something's dark, and it's like, all right, fine. So that could be blood or calcium, we don't know, but I want to look at a filtered phys map, right? And so I look at that and say, all right, fine. It is bright, and for the handedness of this system, that is a calcification. This all makes sense, right? And then just for good measure, I've got the QSM made on there, dark signal, which again, calcification, diamagnetic, all done. So when things work, this is great, and you don't need any. The QSM is extra, right? But the problem that I've and other people have encountered and that my group's published on is that so sometimes you have an area where we have one slice, right? You see that this red part's going to represent one slice here, and you've got this dark area on the SWI, and the phase is also dark. And for good measure, I'll show you the calcification on the QSM is bright. All of that goes with microbleed. But I'm going to do a second slice, right, and say, okay, well, fine. Here now it's still dark, but now the phase is totally bright. I was like, what do I do with this? Like, I mean, clinically, if I didn't have the QSM again stays consistently bright, but here between these two, it's like, well, it's the same lesion, right? It's like so this I would have to call non-diagnostic. I mean, we will usually in reports say probable microbleed, but you don't know, right? And then here, actually, on the same case, this third slice is giving you a mix, right? So that you've got dark and bright. So again, the QSM is mostly bright there. So this off of QSM, you could say microbleed. Based on these other ones, you don't know, right? And so, and what's happening is that there's this phase aliasing. So as I told you, susceptibility is a sort of distortion of the magnetic field, right? And so this dipole is what happens, what's technically happening. And depending for these phase maps, where you're slicing through, you could get very different signals. And so, I mean, our group did a study where we compared, a bunch of patients where we had the same raw data, made SWI and QSM, and then basically found that you were 3 times more likely with SWI to have one of these sort of indeterminate situations, right? Relative to the QSM. For intracranial hemorrhage age, right? So this is work that we've done to sort of looking at how you can tell how old blood is, right? And so just as sort of some basic background on non-contrast head CT, right? We basically within 24 hours to 3 days, you'll expect something bright like this on a CT, right? So that's the hyper intense, in the hyperacute and acute stage. Then you get into your subacute stage where the density that you're going to have on the CT is going to be isointensity gray matter, right? And so that's getting you into your subacute stage, right? And then lastly, you get into your chronic, the old blood, greater than 2 weeks, and that's CSF isointense. So with QSM, people had shown that there's some relationship between the quantitative values, because you can draw circles on here and actually get real numbers back and to correlate with the age of the blood. But the problem that I was encountering is depending on the technique, here I've got this head CT, right? And so these were done like within 24 hours of each other, right? And you can see all this bright stuff here, but this looks also kind of acute, maybe early subacute. But on the QSM, it's all dropping out. It's like, it was this particular type, Medi-QSM, an older one. And then this MCTFI QSM was a different technique that I encountered where they were actually trying to make sure that it was quantitatively more reliable. And there you can see that it matches the CT kind of coverage a little bit better, right? And so what we did is that we, basically this is phantom data showing that this MCTFI, the QSM that Medi thing would make, could make these kind of distortions that this was covering, like making sure it didn't happen. So we had a whole data set where we had CT and MR on all these people. We segmented and co-registered the bleeds. And then basically what we found is that for Medi-QSM, so all of the images were basically were made from the exact same source data, right? You do Medi-QSM, you could have a significant difference in the values between acute and subacute. Whereas if you use the MCTFI QSM, all 4 stages that we looked at were significantly different quantitatively. So again, I bring this up to say is that there's, depending on what technique you do and what application you want to do with the quantitative side of the MR, there's room to sort of explore clinically what new things, depending on the technique that we employ. So now with brain bleeds in general, so this is a relatively old paper, but the idea here is that what they're showing is that for the volume of an intracranial hemorrhage, and here spread across the age, right, the odds of someone dying goes really way higher once you get past 60 milliliters, right? And so that's why clinicians will very routinely get these head CTs where they're like, okay, I want to measure the volume, follow the brain volume. Now, whereas with MRI, it's notorious for being a little all over the place, right? And so like if you really want to follow brain bleed volume closely, CT is what people would do. And they do this ABC/2 method for sort of estimating, right? Where one's A, one's B, and then whatever the slice thickness is C divided by, you multiply those divided by 2 and you estimate your volume. But for the next part, just to get a sense of does anybody know what I'm talking about when I talk about a bland Altman plot?
Oh yeah.
Oh, okay. Oh,
yeah,
fantastic. Oh, very cool.
Not
Okay.
me.
Oh, great. All right. So then this will be silly. So yeah, I mean, the basic idea here is that you got two methods you want to compare. And you can do the straight sort of difference, versus mean approach. Or a lot of papers I've seen actually do difference times as a percent of the full volume, because when you're dealing with really like a set where there's like really big changes versus very small changes, sometimes that can give you more clinical intuition. But the basic idea is that you're trying to see what's the difference from the mean, right? Your bias is the term that they're going to use. And so, things that we use it for is like, again, if I use the method A versus method B, how far am I going to likely drift, or how well do they agree? Or are there trends? If the outliers, if I get bigger measurements, do things go off? So I bring that all up into say that for MR, this paper came out not too long ago where they were looking at non-contrast head CT versus each of these MRI techniques for the volumes you get. And so here you can see that non-contrast head CT is going to say the volume's a little bit higher compared to like a GRE. It'll be it'll be pretty close for flare, but there's quite a bit of variation you can get, right? And same thing, it's going to be a little bit under for diffusion. It's going to be, and again, we're dealing with like 100 mils difference, right? And so that's significant in terms of management. So basically the gist here is that all of these sort of routine techniques, the contrast ones, they all have a bit of bias that make it unreliable so far. So we, with using the MCTFI QSM, went and did the ABC/2 measurements where we had patients where the CT and the MRI were obtained within 24 hours of each other, and there was 99.5% correlation. The bias was 0.09%. So again, really tight correlation. So again, this is a way that if you really care about blood volume, then this technique showed some benefit to being able to follow that. Then in terms of reader variability for looking at susceptibility things, we had an NIH reader study for looking at these microbleeds, really in sort of advance of this anti-amyloid therapy getting rolled out. And so we had an expert panel of neuroradiologists actually create the data set, then a separate panel of 3 neuroradiologists read all these, the either SWI or QSM images, and then call things as bleeds or calcifications. And effectively, I mean, on these ROC curves, effectively what you can see is that it was much smoother if they use the QSM versus for SWI, you have a lot more variability. And what that turned into actual stats was that, for reader agreement, they agreed much more on things being a microbleed using QSM versus SWI, or if it was a calcification or not. And then similarly, their confidence, right? Because I mean, for all of these things, sometimes we have to make a judgment call. And again, the readers were significantly more confident when using the QSM versus the SWI for trying to decide on how to call stuff. And then that too, because it's quantitative, so we actually had the quantitative values for what the microbleeds, the areas we called microbleeds were. And you can see that by and large, the numbers that, that we talked about the positive paramagnetic things being blood, whereas diamagnetic things being calcifications. And you can see here, all these negative things, they were all calcifications, whereas with a little bit of variation, for the most part, all the positive things lined up with what we called microbleeds. All right, so another area that I'm just particularly interested in with the susceptibility in general and that people have published in is in neurodegeneration, right? And so People have used QSM for Alzheimer's disease, and it's actually the latest, ADRC, the advanced MR protocols have, like, they've established this enough that they're actually obtaining this data now. ADNI4 has the data needed to do the QSM reconstructions. So, but they found basically in the basal ganglia, especially the putamen, there's significant differences in AD versus not, but it's not to the point where we could use it clinically yet. And then here's another study saying, okay, well, if you have amyloid beta positive people and they have higher levels of QSM, the susceptibility in the hippocampus, temporal, and frontal lobes, then again, they had greater decline in episodic memory, right, compared to those who did. Getting over into Parkinson's and Lewy body disease.
Was there a correlation between amyloid and the QSM reads, or is that still?
No,
just curious.
As of right now, it's not no. Lots of people thought there should be, and I know several people who have R01s that were supposed to try and find that, but I have not seen the papers that actually say yes yet. So, but yeah, great question. Yeah. And then so for Parkinson's disease and Lewy body dementia, you're looking at the sort of effects of the nigrostriatal pathway. Right, and so in there, right there, with Parkinson's and Lewy body dementia, substantia nigra dopaminergic neuron loss is going to reduce your striatum dopamine, and certainly DAT scans will be correlated with that, right? But for susceptibility, what people have also found is that for here in this paper for diffuse Lewy body dementia, you're going to have more iron deposition, and therefore your QSM values will be higher. Right, so there are ways to people have quantitatively looked at these things. Similarly, though. If you were looking for structural things, this nigrosome 1, if any of you've heard of the swallowtail sign, which, from the papers that I've read, really you need to get like 0.65 millimeter isotropic data, which is super hard to get clinically. But the bottom line is that there's this structure called the nigrosome 1 that it goes away, that when you have Parkinson's disease, and the susceptibility values are reflected, right? So then it gets sort of washed out. And this was another. So several studies have tried to look at sort of how well can you classify. So this one was particularly trying to see the nigrosome 1. This one, on the other hand, what they said was, okay, we're going to go and circle the areas that have where we think the substantia nigra is period, right? And then what they said was that basically the percent of the proportion of your pixels that are above the 70 parts per billion, if you meet the criteria for that, like a certain percentage, then that's enough to say that there's Parkinson's. So you're going away from looking for nigrosome 1 and you're switching over to saying, okay, quantitatively, is there a number that I can use to actually guide me to support this diagnosis? Right? Here's with small vessel disease. Basically, they found that there was people who had some cognitive differences that you could find if you looked at the susceptibility in the areas of the small vessel changes. Again, I haven't really seen this reproduced, so it's I think this is another area that I find interesting, but like in terms of translating clinically, I think has more way to go. Huntington's disease also, people saw higher susceptibility in the caudate nucleus and putamen, but again, this seems like one of the sort of things that, depending on how you reconstruct the data, there could be some challenges for reproducibility. But again, that's what research is about, right? Trying to figure out how we push it that way. And then for ALS, right, so the amyotrophic lateral sclerosis, on the left here, we've got these T2 images. This is a normal person, right? And so this is what the normal T2 would look like, right? And so, and you can see on the QSM, this is the cortex here looks very similar to the cortex in other places. Here's 2 other examples of ALS where you could maybe make out a little bit of darker signal on that T2, but it's super bright here on the QSM, right? And then on this one, I'm not even sure I could call anything on the T2. On the QSM, it's maybe a similar bright, it's a little bright in the other places, but it's certainly thicker also, right? So people have shown that QSM could be useful for ALS. For Wernicke-Korsakoff, this was a case series, but what they found was that the susceptibility values in the mammillary bodies were higher in Wernicke-Korsakoff syndrome compared to the people who didn't. So one of the applications we do here, and that lots of other neurosurgery people will use is for deep brain stimulator placement, targeting subthalamic nuclei. So here is sort of some T2 imaging where you could maybe make out the STN, right? It's kind of dark, but certainly it jumps out way more on these QSM images, right? And that too, so other people have now tried to target like globus pallidus interna versus externa. And so again, on QSM, depending on the resolution, you can get images that will help you segment these things. You don't even have to segment them, like you can see them being separate, right? So that's some of the clinical applications. So this is a more researchy topic, but I mean, again, for this audience, I think it's relevant. Is that for anything quantitative, right? You've got to deal with noise, right? And so basically, you get tiny errors. I'm telling you this example of QSM, but really this is going to be the case for anything quantitative in imaging, right? Is that there's going to be tiny errors here in the magnetic field that mess up the final image, either visually or quantitatively. And so you want to try and see if you can regularize to clean those up, right? And so then the fix, basically we can use some form of math to try and clean it up. And so a lot of people thought CSF is very close to zero, to being water. So let's use that as a regularization. And the argument that I got into people with, well, hey, look, sometimes CSF is not CSF. Sometimes CSF is CSF plus, or CSF plus blood, or CSF plus tumor. And I don't know what the susceptibility that is. And so again, the response I got from people was like, all right, prove it. So with regularization in general, you end up with some sort of ill-posed problem where you can't measure it directly, right? Susceptibility is something that we sort of see how everything is distorted in the magnetic field, and then we try to infer what's going on. Or there's noise, or sometimes you want to bake in something. We're like, hey, look, I know that bone is going to be a certain way. I don't want you to deal with it, so we're going to bake into the model like something that you're going to ignore certain features so that you're not able to get an answer, right? And then there's just the computational issues, right? You got to be able to get an answer in some reasonable time. So sometimes you want to constrain the question you're asking. But so what we did is we had a bunch of patients where we had the multi-echo GRE data, and then we were able to make these QSM images without regularization and then with. And we used the FLAIR images to show us areas that we thought were blood containing CSF versus not. And then and we used the CT when we could also. We also had the CSF mask, because most modern QSM methods will use some kind of mask for CSF to try and get that sort of background value that you're going to use to regularize. And what we found was that basically in people who had no blood, the Bland-Altman plots pretty tight, right, between the regularized versus not regularized. But if they had blood, you're all across the board, right? So the bottom line here is that if you're going to use QSM, and the default is that usually they'll use some kind of regularization, you just have to know if you're trying to do group analyses or something that you're going to, if you have a reason to think there's something abnormal in the CSF, then you either have to find a way to make QSM without regularizing it against CSF, or you have to come up with some other kind of metric, or at least be able to look at what the variations like.
How are they defining bleed versus non-bleed patients? Because a lot of times when we come up with, we're often having to do an LP anyways, right? When they're on their medicine service to see if we can find small amounts of red blood. I mean, almost, right? If we're thinking, oh, is that blood? Is it not? We often get imaging and we're like, oh, we're not sure.
Sure.
So we always get the LP, right? To kind of see how does this compare to like the sensitivity of actually getting CSF direct sampling?
Oh, well, I see what you're saying. No,
I'm just curious how.
So I mean, for this in my lab back in Boston, we did the best that we could do was to say, okay, if the flare, the idea of flare is that it is a T2 image where you're suppressing up a CSF, right? So if there's anything abnormal in the CSF, it won't suppress. So we use that as our metric to try and we had like 1 millimeter isotropic flares, so they were pretty good. And so, but you're right, the CSF will probably be more sensitive. So that would be even better evidence for this one way or the other. Yeah. So yeah, that would be cool actually. Anyway, we can talk about it later if you want. Okay. So going into future directions, right? So this is I'll show you just like 7T susceptibility. That this is actually data that Pratik Mukherjee has been getting over at the VA. Again, you can make in clinically feasible scan times, you can make out all kinds of really fantastic detail about all the anatomy that we just don't get in our standard scans. But after a while, the question is like, okay, well, it's pretty, but what do you use it for, right? And as we sort of and Henry was asking about before, also the field strength, how are things going to be different? At 3T, right, we can say that we can see some microbleeds. At 7T, we see the same ones. They're a bit bigger, right? And at the edges, I think are a bit sharper, right? And on the phase images, you can sort of see that it makes everything jump out a bit more, right? So in reality, all of those microbleeds were present on all of them, but the 7T just made it more likely that you're going to be able to find it. Separate from that, right? So what Pratik's been doing that I'm super excited by is this epilepsy patients, where what he had found is that in normal 7T SWI, you get this sort of dark ribbon around the cortex where these blue arrows are, right? And then there's areas, he's found in areas of heterotopia that it's gone. but you don't see that band along the cortical margin. And, I mean, I get that's sort of like, okay, well, you have to take my word on it with that case. But this one, I thought was quite cool. There's a focal cortical dysplasia on the T2. You can sort of see that line coming down here on this other the T2 weighted image. Again, you can see all this abnormality there. And then, so while you can see that normal band in normal areas, this is the area that we're looking at, and you see the band is gone, right? So being like, while I certainly would like to believe that I would see these two things, I'm much more confident that I would see these areas of like missing bands, right? So again, I think it's sort of an exciting application. And back in Boston, at least, one of the hospitals had a clinically certified 7T that they were doing this MS and epilepsy studies on to look at these kind of things. So then with QSM, we talked about, there's all these different types, but one of the things that I found super fascinating with QSM is that, like, in the setting of MS, people have been looking at these. I mean, this is relatively old, and I get this is Henry laughing is sort of
no. I was looking at I was laughing at the that you can see it in both.
Yeah,
that's
right.
really interesting.
Yeah, well, I mean, but that's the issue. So in MS, right, you've got when people have multiple sclerosis and their lesions are active, they will often enhance, but there's like a window. It's only a couple of weeks, and then it's gone. And then there's a subset of these lesions that, even though the enhancement goes away, there's some sort of like low-grade inflammation going on, the chronic demyelinating lesions, and they'll keep growing. And so, these lesions are one of the markers that people use for trying to decide if a drug therapy is working or not, right? And then to change drug therapy usually takes like 6 to 8 months of a lot of headache, right? And so, again, being able to catch this stuff earlier would be useful. And so here's an example of using this tracer where, you see the chronic demyelinating lesion. I tell you, this is not enhancing, and you can see it hot on this PK 11195 PET. Here's another different patient, same deal. You can see it hot on the PET, and you can see it on the QSM. But then here is one where you can see the chronic demyelination lesion and nothing, right? And whether this had to do with like some genetic background or I don't know. Same. Here's another case, another chronic demyelinating lesion, nothing on the PET.
So the PK 11195 is.
That's the first gen.
That's the first gen PSPO,
right?
That's the first gen.
Right.
Yeah, so that one didn't have the susceptibility.
But there was a lot of 20-30% would have genetics that would not. Or is that correct?
Not for this one.
Not for this one. Not for this one.
Oh, right. The second gen. Right.
Yeah, second gen.
Yeah,
it's the second gen.
Yeah.
But again, my hope is working with you. I mean, we've got these sequences all set up on the PETMR also. This sort of thing, getting into the realm of neuroinflammation, trying to evaluate infection, or the sort of low grade, the stuff that we can't see on regular imaging. To me, like for neuro, this is what I tell my trainees. Like, I mean, I love lots of things in neuro, but I will say that the sort of frontier of new generation tracers along with advanced neuroimaging is, like, to me, like a super exciting future that we can potentially have in neuro.
Tim, I wonder if there's something with the RM1 that we could incorporate. I don't know.
The PK 119. Yeah.
Well, not the PK.
No, but the
QSM.
The QSM.
Yeah.
Because that actually would be.
That would.
Because we're
going to do the DPA, right, for neuroinflammation, but it might be interesting to see what susceptibility you see in these patients, just as a patient population.
Right, because we haven't decided if it was CT or MR yet, so we could do the MR. I just stabbed this.
No.
Your heart there.
Oh, we should talk about this.
We should talk about that.
Yeah,
we could go on forever.
No, it's great. But I mean, if it is a CT or MR question, again, hopefully my earlier slide could convey to you that we could get some of the CT features out of the MR also, if that's what you want. Okay. Okay. So now,
actually, we probably.
Okay. So the next part of this, this touching back on, I mentioned this earlier, QSM is this net, at every voxel you've got this net paramagnetic diamagnetic balancing act that you're looking at, right? And the reality is that for every voxel, right? So at the best we're doing 1 millimeter isotropic, and so you have potentially 10 to the 8th neurons inside one of these voxels, right? And so something's going wrong with some part of the neurons or their support cells or whatever, you're getting the net. So one of the newer techniques is that we're collaborators from Berkeley have come up with is decompose. I mean, there's different flavors, but certainly Chun-Lei Lu's group has this decompose one that we can do here, where you can take the QSM data and actually split it into the paramagnetic, the positive, and the diamagnetic. And so here, I mean, hopefully you can see that all the sort of gray, all these deep gray structures are known for having lots of iron in them. you can see them really well. Whereas the white matter things are really popping out more on the diamagnetic, right? The negative susceptibility map. And they were working with the people at Mayo, they found that basically using this decomposed method, amnestic dementia subjects had higher gray matter diamagnetic susceptibility, right? The DCS would be higher in those people. And then, okay, so now getting into OEF mapping, right? So, the idea of oxygen extraction fraction mapping is that, you want to look at how much oxygen functioning brain tissue is sucking out of the blood, right? And to me, it's a proxy for how metabolically active the tissue is. I mean, the tissue could be dead, it could be stunned, it could be normal, it could be having to work extra hard. And the reality is that cerebral blood flow also messes with this some, right? If an area is starved for blood, like it has a diminished blood supply, the oxygen extraction fraction is going to come, right? People talk about misery perfusion. And so combining cerebral blood flow with cerebral blood volume ends up from the OEF gives you this sort of CMRO2, right? But the idea is that the brain is trying to conserve its OEF, maintain it by doing all kinds of normal homeostasis kind of things to the vasculature in the brain, right? Oh, come on, there we go. Yeah, I mean, so basically, it's sort of the idea is that ultimately the CMRO2 is telling you about how much oxygen is actually being metabolized in the brain. So, I mean, people have tried lots of ways of doing this with blood, right? Using deoxyhemoglobin versus oxygenated hemoglobin, which, as we talked about, is to have different susceptibility values, right? Could impact the images in different ways. And so people have done really elaborate laboratory experiments where you have inhaled O15 PET or all kinds of other tracers being used, and ultimately they've shown that for stroke, for tumor, for dementia, and for the MS and hepatic encephalopathy, there are significant differences. And there's been a bunch of different techniques, which people here, we've got where they're trying to get a sort of global picture of OEF by just looking at the superior sagittal sinus data, which, I mean, I get what they're doing, but I found it a little hard to get excited by because it was so nonspecific. Then there's sort of work that was going into venous structures, but then finding the venous structures, again, that's a bunch of extra work and segmentation. Focal gray matter, once I started seeing maps like this, I was like, oh, okay, this could be cool, right? Okay, well, we can start seeing some anatomy that I can correlate with some pathology that makes some sense with, they're either how they're neurologically behaving. And then sort of moving on to this QQ-OEF method that I've been working on, which effectively takes QSM, but then also takes the raw data that the QSM is made from and tries to give you an estimate of what the arterial side of the oxygenation is versus the venous side, and then gives you a map of what it thinks the difference is, right? And so that's the sort of the work I'm going to talk about in the next few slides. So this QQ-OEF, they validated against O15 PET. So again, we got here, they have a bunch of healthy controls with O15 PET scanned twice and then done an average, right? And then you've got the QQ-OEF, again, scan 1 and 2 in the average. What they found was that the Bland-Altman plots for PET versus itself, right, had, this is just a scan, rescan sort of bias, right? Same thing for the QQ-OEF, scan, rescan bias, pretty small, and that the correlation between the two was pretty good, right? And so ultimately, this gave me some faith. It's all right, this could be useful to look at for clinical things. And then they did this other work where they were looking at hyperventilation. In hyperventilation, basically the oxygen going in your brain is going to have decreased oxygenation, right? And so you'd expect that the oxygen extraction fraction should go up. So in these controls, again, they showed that, okay, make them hyperventilate, yeah, the OEF goes up, right? So all these things made me think, okay, this could be cool. And this method is obtained from the same data that we do for the SWI. Or you're not doing any extra scans. We're just getting the raw data, processing it a different way, and then making these maps, right? And then here, since I came here, Dr. Niall's group has been kind enough to share with me data they have from Cedars-Sinai with pre-diamox, post-diamox, right? And so this is a relatively healthy control. And I get that you can't really see the differences here. So on these OEF maps, but I made a subtraction map between the two. And so effectively what you can see is that you're subtracting the post-diamox. So for those who don't know, diamox basically makes your blood vessels dilate, right? So when you give somebody diamox, the idea is that everybody's got some vascular reserve that, if you got frightened or you had to run away from something, part of what your body might do is vasodilate to try and give you more blood so your brain can do whatever it needs to do, right? So you give the Diamox, the idea is that all these green areas are areas where the oxygen extraction fraction went down, right? Because you're getting more blood flow, therefore, blood flow that the body didn't need. The brain didn't say, hey, I need more blood to these parts. So the amount of oxygen being sucked out is less because you've got more blood coming through, right? It's kind of like, yeah, basically the water supply got much higher. And so you're still drinking the same amount, you just don't need as much, right? Because it still keeps going there. So there's a second patient though, where vascular path, definitely things are bad. There's the pre-Diamox imaging, there's the post-Diamox. And even on this, you can see some areas that are just really quite different. But then when you see the changes of pre and post-Diamox, you can see it's like there's all these red areas mean that it actually, the OEF went up in some places. There's only a handful of places where you got the expected reaction, right? So anyway, this is results that my group had done looking at white matter lesions in people who had MS, who were on therapy versus not, and versus healthy controls. And we saw a significant difference in the OEF values that you get in those white matter lesions. This paper is under review. We're here working with the epilepsy group. What we found is that this is a focal cortical dysplasia that you can see on the flare, right? And here on the OEF, the map, you can see an area that just sort of jumps out, right? And so the hope is that, like, while this FCD you could see on the flare pretty well, there are others that are more subtle that I'm hoping that we can try and use versions of OEF to be able to tease out. And again, you know, I mean, we're obtaining the raw data anyway, right? So long as we obtain it in the right way to keep it, then we can actually look at these extra features. This is work that we've got in review where basically in type 2 diabetics, what we found was that if you look at their insulin resistance as opposed to just their A1C levels across several brain neural networks, the ROIs for there had significant different OEF values between the diabetics and non-diabetics, right? And that also was like if you saw this insulin resistance being elevated over multiple time points, they were also much more likely to have cognitive decline over the time period we were looking at.
So it increased oxygenation.
No, reverse. The oxygen extraction fraction.
Oh, the fraction,
right? Yeah. So it's actually it's basically more misery, right? Like you've got lower levels of oxygen left over.
Yeah, gotcha. Okay.
Yeah.
Yep.
Anyway, and then so in terms of future frontier, right? So I mean, again, we talked about a bunch of the dementia, epilepsy. I'm working with the TBI group here, working with the MS folks here, and with you all. The hope is, especially with neuroinflammation, you know, and in terms of like, while certainly I've been working on making these clinical collaborations. I've also been building all this sort of infrastructure here to be able to obtain the data, recon the data, make it into analyzable format so we can do papers that prove that this stuff is useful. But then also, you know, like there's issues like there's times where getting to smaller resolution would be super useful. And right now, you know, like we can still do like 0.8 millimeter isotropic in like 6 minutes or something, but that's getting kind of long and it's expensive for scan time. So there are newer techniques that he's already gone, but some of my collaborators here, we have things that at least right now can get it down to 2 minutes. We're going to like 0.75 isotropic, right? And so once you do that, then all sort of stuff's open. But we can obtain the data. Now we have to actually get some data. Like we can mechanically actually do it. Now we have to build the reconstruction and then start doing the studies to prove that it's usable. You know, and again, getting these smaller scales, we can look at cortical architecture and microvasculature, getting down to like these higher resolutions. But then also there's clinical applications, right? So some people have said that the tumor microenvironments, certain gliomas, they think that the vessels actually show you some different kind of patterns that we might be able to use for diagnostics. Neurodegeneration also, people have, looking at OEF changes in like the cortical levels. Some people suggest it might be related to being able to see people who are going to respond to certain therapy better than that. So anyway, we went over a whole bunch of stuff, but I tried to stick to susceptibility basics, some clinical applications, future directions. And with that, I thank you for your attention, and I apologize to anybody who got lost.
Oh, that's great. Thank you for the overview. And it sounds like we now have all the MRs here, right? Are now programmed. Is that correct?
So I can do it. So we have a neurodegeneration protocol that can give us one type automatically. So that, and it's only on our 3T scanners, but both for GE and Siemens, all of our 3T scanners, it is capable. If you order neurodegeneration, then it'll definitely be in there, a version of it. If you want to do something fancier, or if you want to do it as part of a different protocol, I've worked out the way that we can custom do it for now. We're working on like the new MS protocol will have a version of this in it also, but I'm working on trying to get it into like our general post-contrast protocol. Like basically anywhere where we do SWI, I'm trying to replace it with some version of this. But there's trade-offs of scan time and what people want, and so that's where right now, I'd say if there's any case where you want to look at this stuff, or if there's a population where you think it'll make sense for us to do it, just communicate with me. That's how I've been working with other groups now.
Great. Yeah, and so interesting of the long COVID is that some folks with Gladstone using kind of mouse modeling have shown that there are probably actually perturbations of the blood-brain barrier because of these amyloid fibrin clots that can form in the microvasculature and the neurosystem, and that might actually lead to basically a leaky blood-brain barrier. And it may also potentially, there's also a lot of endothelialitis and microvascular insult, or at least again in some of these animal models. Whether this is actually happening to people or not, we have no idea. But with the QSM, would this be a better way of looking in some of the brain parenchyma, not necessarily just the CSF leak, but looking at if there is damage to the microvasculature? I guess would that impact the oxygen extraction? Would it impact potential microhemorrhage or things like that? So just curious of kind of how to look a little bit finer tune out just the regular sequences that we would be getting or are getting for some of the MR study.
Well, I mean, everything you mentioned is like that's literally, it's why I left my job to come here to go do all this stuff, right? Because I want, like, working with clinicians like y'all who ask these kind of questions, but also have really, really well-defined patient populations. I think it's the only way to move this forward. Is like to say, okay, we really do believe in what we're imaging. Like when we say that there's abnormalities of these patients, we believe them, and then now let's do the best imaging to actually prove how this all works, right? So my suspicion is yes, but we need to prove it.
I'll prove it. Yeah, the other thought too. So we have a project actually. Amanda's a PhD student in our group, who will actually be looking more at tissue-based imaging. So we have these autopsy specimens that are collected from people that die suddenly out of hospital. So we can essentially get brain tissue from people, and the whole question is in people with HIV, methamphetamine use, which we know is not good before, and it's a big problem here as well in our especially in people living with HIV here in San Francisco. It's a very high burden, and so part of this is that we are trying to implement these kind of neurodegeneration TSPO agents for PET imaging. But I guess then the question for you is, would you see a role for some of these more advanced MR modalities within the setting where we know where methamphetamine is going to be causing more inflammasome activation? Probably. Anything about blood flow with methamphetamines? Is there much even talked about that in the brain, or?
I didn't see anything, but there was something in your talk when you talked about the dopaminergic neurons. Would you be able to look at that like on autopsy tissue or not?
The yes and no, right? Or rather, like, so certainly one of the things I would love to work on is the sort of the imaging path correlation that you can get. You need a different setup though. Like, I mean, it's certainly doable, but like all of the pipelines and things I built are around like whole human brains, right? And so it expects certain things to be there. But that's to say that my collaborators have definitely done all of these things, and people, the data sets exist to be able to validate all this stuff. So if you wanted to do that, that would be something exciting that I'd love to talk to you more about.
Okay.
Yeah, that would be really cool. Yeah, we can do that. Yeah, make those direct pathologic correlations with a lot of them. And are you looking at any people that get biopsies subsequently to see how? Just curious how the correlation with.
Because I'm working with the neurosurgeons now on GBM study which Chunlei Liu and Javier Villanueva are all on, and where I think last week was the first time where they actually took some of the QSM maps and actually gave it to them intraoperatively to guide where they're biopsying. And they're getting these like digital pathology things to go along with the GBM. And so certainly they're all doing susceptibility and doing the decomposed stuff, which I certainly think there's promise. But I'm really, out of that same data, we're talking about doing the OEF mapping. So then there'll be these path samples to go with the OEF. And along those lines, if for the cases that you guys in ID get biopsies on, I'd love to be able to do that correlation, right? I mean, and neurosurgery has basically already they've paved the way, like to the point where these high resolution path images end up in our packs along with the where they did the biopsy stuff plus all the other clinical imaging. So I don't think it would be that impossible, like that much of a lift for us to be able to reproduce that in these ID patients. If you think that would make some sense.
Yeah, we have, unfortunately, we have a fair amount of PML here in San Francisco still, which is unfortunate, but we do have a population that just can't access care for some reason. But we're also seeing things, on the transplant side and immunocompromised with PTLDs and things that are relatively, especially in the brain, are difficult to diagnose without biopsy. Things like I think there could be some interesting, kind of correlative
studies
that could be done, because we get the tissue, you get the whole path reports, and if there's it would be great to kind of correlate back with some of those sequences. Excellent.
Oh, great. Well, thank you all for your attention.
Thank you very much. And then take me food.
It's just outside.
Is it outside? I can So help yourself, take some to go, I think.
Hopefully the vultures didn't have to.
Oh, that makes sense.
Really?
Oh.
Yeah, this is very
awesome. Hey, cool. Hey, so nice to meet you. Okay. Okay. Oh, it's your case.
Yeah.
Okay, so we're meeting. Okay.
Thanks for coming.
Tuesday,
Right?
Yeah, that's fine.
There's a population in space.
Right there. Oh, yeah, what's the search? I can look at but I have no office here also. So I mean, that's what I'm saying. Like, we can meet wherever you like. I'm any of these things. I have space upstairs. I have space across the street. So we decide. You just come.
Yeah.
Same place with the MRI.
Yeah,
I don't think I've been.
Yeah, I just
probably haven't seen yet our package.
Who's at FedEx? So we had a FedEx fiasco. I should have tweeted that.
You should.
A few days ago as well.
Well, on place there's some pizza, cookies, some water.
we can set up
Thank you so much.
right now
You can pull our package.
Well, you're saying with what's in there, we can
On one of the
we can change it.
Okay.
Exactly there.
Yeah, that's what
But not next to Joe's.
Well, yeah, exactly.
Never been.
Because the ones
And also,
we're getting off the GE
that we have
getting
placards that we put on the side that said radioactive.
I think they're a little bit longer.
They wanted
than
them-
Saturday or so, but not.
We have a pouch.
Yeah, so I think
Put the stickers in. Because then
Yeah.
what you do is pull the sticker out,
Okay.
flip it over, and it's got empty, so then we can send it back. These are reusable.
Sorry, the AMR.
Never
AMR
issue.
I made it.
Thousands and
Oh, they
thousands
didn't
of
send it.
packages. that
I'll
are
go
straight by
back.
FedEx.
We need
Today,
like
It was an issue. We want it
Yeah.
physically adhered to the side of the house.
they have.
Can they get it later this afternoon?
Yeah, they're bigger than the picture. We're gonna fix it. So when I first.
So that's actually.
So that is, okay, so they just
Yeah.
failed to come yesterday for us.
No, it wasn't really raw. That was.
Very nice to meet you.
That part, that part was fine. But it's it's gotta get past.
Oh, really?
I'm gonna go.
Let's go. You can do it. Always like.
Or brain cells, or do you plan? Probably.
What do I do? What do I do? They do nothing. They just
Really?
Now that we start thinking about.
What are you doing?
International rules. International.
I'm gonna see my like friend
So
from college.
tomorrow, I was just going to.
Lives in
We don't have a patient. I was just going
Either
to.
of us.
No.
Yeah, I just.
Respect to see each other.
Yeah, no, it's all under Soman, whatever.
On Sunday.
Which we do.
Follow.
Friends in our
Yeah,
business.
that's
Thank you. Okay.
It's not required.
Again, sorry for all the trouble, but thank you for your help.
And he's like,
And thank you for agreeing to look at that resting state MRI. Oh, the resting state MRI protocol that you have in there?
Yeah.
Yeah, so that's one of the videos we're using.
Because
I saw this, it's well packed. I saw that. Yeah, exactly. Yeah, it's not gonna fracture.
It's like a 20, but so what do I do is like I just do one
Fingers
round.
crossed.
I increase
I hope so.
phases, so that they can treat like 9 minutes instead we apply the spinach.
Today.
Where was it going today? It was going to New York.
So it's like totally 9 minutes and 40 seconds. So
Yeah,
it's
so
like
afterwards.
Oh my God. That's awesome. Okay, well, okay. I hope that's great. I mean, anyways, the paper that I sent you, like, I was basically trying to find out what are people accelerating, because I mean, even talking to Leo, he's like, oh yeah, most people really want to have 20 minutes.
And then
That's not very useful for long, right? So anyway, this is awesome.
I have this friend
We'll
that's
see what
like a
happens.
food
yeah,
writer
we just keep running.
for SFA.
It's nothing different.
We're building
Makes sense.
Making sure.
basically he's gonna offer us like dinner.
Somewhere on the floor.
What's it called? It's called the pawn shop, and it's like you have to
Just got
go
real
through
big.
a pawn store, and like it's like a speakeasy. It's not clear where the door
Came
is.
right in
This wire-
And then there's another layer, it's like the hidden thing. And that's so that's what I'm doing on Friday.
Exactly right.
This one's veggie,
Where's it from? Where's it from?
Goat Hill.
Oh, where's it from? Go Hill. Go Hill.
I mean, to be, we used to get the Costco.
Yeah,
pizzas.
work-wise,
To be
there's
fair,
been
probably
a bit of
remember that.
God paper. I just do so much analysis.
And
I'm just getting confused between the different studies, but you sent me the MSD. Is it MSD or MDS? MSD data for a link, sorry, for the link that paper?
So the ones I recently sent you, that I rated, those are for the link. That one's split between the Prevail and some Smarts. And then the MSD ones, those.
like in
I think some of them are gonna be for
it's supposed to be
the paper, I'm not sure.
Okay.
Like what we kind of find. And then
We're
What,
putting together.
were they
I
prevail
talked to,
people or?
We'll have some write-up for you.
So it's probably going in the prevail paper.
Prevail and then some Outsmarts, which is mainly Peters.
size.
When did we,
We'll see if we can,
we're not planning to do
yeah.
MSD
Yeah,
on
that'd
the,
be great, because that's super exciting.
On the
MSD on
T-types?
the gut, or are we?
We already did that.
Sure.
Oh, so that data's
Yeah, I
already.
think.
Yeah, that data is from you, I believe that should have been replaced one.
Because, first of all, from, you know, COVID.
We still need to wait for Tim to get that.
So I don't know.
And I think once they come out with the second spike of acid for those,
With the antibodies, right? We don't have the,
I don't know what that will, I wonder why.
we're not gonna be able,
probably
if we do get
in the future.
Rotating from
it's an antibody.
The company
We're
hasn't
not gonna be
even.
able to put it in humans because of the GMP issue.
Yeah, it
So-
has-
We only know that this
We
will
have
work for
to,
spike because the owner of the company told us.
Like the AIG.
We have to
That's the
consider.
sequence that I've been acquiring. They went on the GDF stuff. It's all, that's the one that you basically took. roll
Looks like there's a couple there that we
So that's why I could be like 5 minutes.
And maybe it'll get in rapidly.
Figuring out that download CV.
And we'll put it, so we'll work with you on getting
All the outpatient text, but regardless, I can get the raw data.
That'd be great.
And we can all reconstruct whatever. So, yeah, exactly, right. So it's been fantastic. Thank you.
You don't have an animal model for GP 41.
And then the Cornell folks.
No, I have the fellow. No. Nothing for- I hope we did. Maybe good upregulated.
You guys following the summer house drama at all?
Yeah. No, you got the one for GP 41.
That's what I know.
Little bit about they have some plans.
Yeah, because I don't know how we'll. Yeah, 'cause I don't know
All
how
over
we'll
my
assess that.
Instagram, so I'm like, everybody is.
Little now.
All we'll have is find it to the.
But that's.
Come on.
Well, I mean, we have.
Basically.
Stocks, the 41.
Okay,
Sometimes they have some.
there's a couple,
Good knowledge.
Amanda
creative
and Kyle, and they're married. And
Yeah.
it's just a very like, what's blah, dude, like, he doesn't sit that nice. He's fine, he's being fine, but like, he just parties too much. He's cheated on her, like, others have come to 6 a.m, you know, she's like, doesn't talk, she's so married.
It's gonna be away.
now the relationship is falling apart on the show. Like she's totally checked out. And
This
he's
worked
like,
out well. I'll have to go.
why don't
back
you
to
love me?
the guy who said that he's
Parallel story. Sierra and Wes.
This is such a place where they dated. Sierra's going together was like 30 guys. They dated and like she was very like the whole the whole season of the show. Super close. She was like, I'm not gonna like get up with you unless we're gonna date. Like I don't
Yeah,
really find intentional.
there's even some of the smaller rooms that are around here
And then
too
like
that are.
finally they
Yeah, the ones across the hall here too.
started like actually
Yeah,
dating.
the one across the hall.
Super.
Yeah.
And he said that very much time where he like explains like, oh yeah, we just saw each other as a person and like I just lost interest or whatever. So like there's like fun.
It is one of the ones like-
It just.
Right.
But it's.
They're very
It's not hard. It's just.
And then the next season. Just there.
Well, so I remember. Yeah, and it also had a view.
This season,
Yeah, it's on, so.
we're watching Amanda and Kyle like all apart. We know that they get divorced after the season ends.
Where did you end up talking?
And
Is that-
Wes
is
and
that all?
Sierra are like trying to become friends again, being very
No,
friendly.
no, wait, no.
Everyone's like they're gonna
I'm
go
still there.
together.
No, I was basically about.
And that comes out in like
Plaque is still there, I think.
outside
And
the
the
show.
plaque outside is still there.
Amanda and
Even
Wes.
after all that, I think it's still there, actually.
And Amanda and Sierra are like.
Did they, yeah.
Sierra's like,
Yeah, it's still out there. You can get rid of it. No, it's like.
like basically.
Plaque and the seat.
like being
Me too.
So for ARI that's
Oh, my God.
when
Oh my God.
ARI is based here, right?
Right now,
Leaves
like,
this
there's no way to
shit
know
over.
I do. Do you not have one?
Hi, Sierra.
And,
We gotta come get a shirt. We gotta shirt everybody out.
Oh, yeah.
She started picking up.
if I.
Wes also was like,
Give us
still.
something between-
I created
Elf
two more.
at that like Wes.
Email girls.
Okay.
I don't know.
We have a stipulated affiliates group.
Huge drama.
Which is
Yeah.
everybody.
Oh,
It's added to that group, so I'm not adding individuals. I'm not the email address, like.
Well,
I'm mad.
there's a way to write it.
It's the advisory board.
Like if-
Okay, kinda like-
If I get-
Okay.
So my data gets.
Kinda like we have the core
Whether they want
interest
to-
system.
Right,
Yeah, but I don't know, so I told Val, hold off on sending anything off to,
So, and,
Amanda's like,
was it Melanie and, no, Monica,
They
and
wouldn't have even like plugged it. if
Joel,
they know it's
yeah.
now, and, like,
until we get our final tally and then meet on Monday. If we
Okay.
roll.
So literally all you're doing
well,
is
So,
painting.
like,
I've got another meeting later in the afternoon, so I'll have to zoom in.
Okay,
Yeah.
yeah. So then, as long as you don't feel that way, that's.
So lots of
I
commitment.
want to come over.
I'll put them in that.
I feel like I have.
They were both in it.
I'll just see what I want to do.
Hannah Burner was up the road.
Good.
Not on it for that long. Okay.
All right.
I mean, we understand.
That was the other thing.
Like just for the wild.
So-
maybe the wild.
Yeah.
I thought when we talked to Jeff, because I looked through that stuff last night, it's pretty good to me.
So what's the premise?
But I didn't comment back to him, so I had a question for you.
Yeah.
I thought we had told him to put me on, but not me, not you, right, right, I seem to make it on there as well, yeah.
Oh, whatever. And-
Because we want to try, we want
And I was
well,
like,
I can let it out.
yeah, because we don't want to have our name on every single one, like,
Oh, you know, I didn't- shoot, I should have caught that when I emailed back briefly.
Oh, it's just on the weekends.
I can absolutely, I can email back,
Okay.
because I haven't been in contact yet, but I thought this was good.
Have they changed the classical or like?
Yeah.
Like,
Yeah.
have they introduced like?
I know he asked that question about the personnel, but it
Although one of them.
depends on what
Really? in it?
what
Like,
personnel.
Yeah.
Okay.
Looking for.
Yeah.
Maybe that's right. Check it out.
Because it's
Yeah.
restricted on.
We have like a.
Right, that was the,
Prototype version of the
It's so
notice.
interesting.
but look, I don't,
They're
I,
like doing like Vanderpump.
we're not
And
gonna,
then I haven't checked all the.
we're not gonna,
They don't-
at this point, let's look into science, see what they're doing, and we can work with them on their budget
Right.
stuff, right? I mean,
I
yeah,
feel
I
like
agree.
they can't. That's insane.
And.
It's not like the NIH,
Really, Bravo.
it's not every I is crossed,
Right, exactly.
I is crossed and T dotted. So I'm trying to say. We don't have to have everything perfect.
Exactly. Made a statement about their compassion.
I know you want an infection. Cells and infections. I know you do.
No, but at least have that as a patient.
Yeah.
So I can only, I don't.
My colleagues, remember, oh, he's a very bad Lorena. The daughter got married.
Really?
Because that's what they
Wow. Oh, wow, sure.
Get the whips from.
But not. Like,
Is that in South Asia?
I mean, that's something.
Yeah.
you know, they're here.
They're here.
They're actually out somewhere.
Oh, but that's an Indian.
Like this is
Where wedding?
That's
amazing.
Yeah.
Wow, that's a super. And does she have the henna on her hands?
Absolutely.
Yes, yeah. She wasn't very bad.
Oh, okay.
They're working so hard to like. A little bit more like Bob.
More like Bob, yeah. Being Bob and
Look at
Sons,
him.
yeah.
That's
a great-
There's an episode like yesterday.
Mm-hmm.
Oh, that hair?
And the hair, and the hair. What the hair?
That's
I wish-
so
Yeah.
cool. Do you remember Mary Beth? She used to sit behind me. This is her daughter.
Oh.
This is
Oh, they got married in the rain? Oh, I got married in the rain.
They did.
Oh, yeah,
It was pouring wind, yeah. We were supposed to have ours outside in the Arnold Arboretum in Boston, which is gorgeous. It's like,
What is
it
the
was just
other option?
pouring rain. So,
Oh, I want a brownie instead.
up in our living room.
The woman whose seat you're sitting in, she retired last June. This is her daughter. Wow. Oh my God, what a beautiful dress.
How is she doing? By the way, have you heard from this time?
Okay. Oh,
Look at his
okay, awesome.
Oh my God, it's stunning. You know Mary Beth? Feather.
She retired last year. She was working with Cheryl Sauter, who's our.
Jewelry.
So
Anyway,
But look at
that's-
the flowers. That's like put it over each other.
Oh,
Really?
But yeah,
You're married.
so she
Oh,
retired.
look at his.
But she was like, she was there
Yes.
before.
Amazing.
Mike
Yes.
McCune.
God.
Like that, like they all came with DEM.
Friend who got married in
So they
Greece.
pre-existed.
Not a flower like two things, but like they shut flower.
And many of them actually.
Head brown.
Yeah, did you get food or do you want? You're good. Yeah. But thank you so much for.
Oh,
Yeah,
yeah.
that was great.
Yeah, okay, good.
No, and I wasn't laughing at your slide. I was just like, when I saw the PK, I'm like, oh my God,
It's very
there's still
cute
PK
to see.
dead out there.
Yeah, no, it's true, right?
Oh, photos, yes, right. We got a photo. We need this for our.
Yes, let me get your CIDMI t-shirt as well.
Ruthlessly use this for fundraising.
You know, you should get Peter in also, master thesis.
Should we do it with the background outside?
Yeah, let's do that because.
Or is it too bright?
Oh,
Yeah, the backlighting might block it out.
it might be. We also have outside, we have the board.
The board.
So maybe we do it with the
Well,
board.
actually, you could flip this, so it wouldn't be bright in the back.
How's your week going, Manny?
Yeah, I can't even sign.
Got food in my belly.
Mm.
Got sweets in my belly.
You take some more for Brian? Yeah, we should.
I was planning to take the rest for your Brian. For the rest of the
Is Nabil like off for the summer? Is he away? Is he?
His
said
email
yesterday.
expired in like 20 days, so
Okay.
it's likely. Unless he's able to stay.
Nice.
Do you know if Nick was able to confirm to be able to stay over the summer?
I think so.
No bad.
I'm pretty sure.
No bad. I do. You're fine. I was thinking. There we go. Oh, you're fine. You're good.
I don't know what his position would be or how the hiring thing is going for that, but I'm just be whatever student scholar or whatever.
It'll probably be like visiting scholar or something.
Oh, is he not getting paid?
All right. Thank you.
I think it takes after like summer credit for class credit.
So that, all right.
What time is it? I was
Yes,
just
yes.
confused as a visiting scholar. I don't know.
Yeah,
It
yeah.
wasn't a huge thing. So.
I feel like that's one thing that's different in Canada versus the US, like so many unpaid things here.
Oh yeah.
All the undergrads working like so hard in these Berkeley labs, and I'm like, they're not getting
And my friends would come in to the lab like at 5 and they wouldn't leave till like 4.
That's like,
And then go to class.
yeah,
And
yeah.
they'd be like, oh, you know, just gotta do it because the GSIs want
Need
you to.
papers, blah blah blah.
And then they won't even be getting any credit or anything.
Yeah,
They'll be like, oh, just be glad for the experience.
I worked throughout undergrad and research stuff, but I always got paid, but not very much. But like, I was working for free.
Yeah.
Talk a little bit about.
It is kind of crazy.
Specific, not the whole.
I feel like people do that for like one semester, and then if it goes well, then they'll obviously be getting paid. Yeah, it's not like a long-term unpaid situation. That's like very.
At least summer, like the stipend, I felt like was like I don't know. I felt like that was fair. Like you come in like what 2-3 times during the week during the school year, so like we can't pay you for that. That's fine.
Mhm.
I still got credit for it.
Yeah,
But I was full time in the summer, so I felt like that was fair.
absolutely.
Like, it was nice to be.
Yeah, I guess if you're getting credit, that's fine. I feel like you should still
Yeah, I mean, I know some people who like went to AC stuff who did get paid during the year, and it's like that's really cool.
yeah. Yeah, my master's, I worked in a lot of money to get paid, but it was like part of my master's thesis. So it's like kind of like getting credit.
Yeah.
Actually, no, I did get credit for it. I didn't take any classes, which was fine.
Yeah.
Like,
Yeah, like in undergrad, like some of the labs that I interviewed for, they were like, oh, like we won't be getting you paid. Like it'll only be
for papers.
like through like school credit, like not even like beyond papers. And I was like, I'm already kind of like maxing out the units I have just so I can like
Yeah, to like
kinda,
finish your major. Yeah.
do my major or like do like a minor or something like that. And they're like, oh, like sorry, like, you can't offer you anything. I was like, I don't want to take like another job. Like I'm already working as a tutor. Like I'd rather not do an unpaid job. No, thank you.
I mean, it just adds like if you need to have research on your resume to get into like med school or grad school, it just like adds to the fact that if you can't afford to not get paid, then you can't get those opportunities. Like,
Yeah, I feel so bad for undergrads like looking for research. It's like at least not so much at UCSF, but like the labs at Berkeley too would always ask like, are you pre-med? And I would be like, no, because then they don't want to hire you because they think like you're just in it for the checkbox.
yeah,
And that's not true. Like obviously, like in order to like put it on your resume, you want it to be like an actual good experience.
yeah,
like,
you want to have a good
contribute.
reference.
Right? So like,
And even for med school, like you want to have your name on papers. You want to
So-
contribute.
That actually was pretty good,
Yeah, it was good.
but with number of feet, I'm glad I went on from 4.
yeah, it's a good amount. Those cookies so good. Like
The
I
audit
love a
house.
little too big for them. What are they called? Palmiers or something?
yeah.
Oh, really? I call them audit house.
Audit house?
Audit house.
Orejas?
Ears in Spanish.
Love that.
So it kind of looks like a little ear.
It
Yeah,
does.
they do. That's so cute.
I don't know why I heard butter house. Okay, what time is the next shuttle?
So we actually did, these are not the
I almost missed the shuttle on the way here.
Oh, no.
Like the guy was gonna start taking off, but he saw me like running and waving, and he just kind of like stopped.
I
was
love
like-
when they stop for you.
I was like, Mission Bay, right? He's like, yeah.
Yeah, I think that the Mission Bay one doesn't come for another 30 minutes.
Oh, dang. Okay.
That always happens to me at Parnassus.
Huh?
Like I'll finish and I'll be walking down and I see it taking off. I'm like,
But 30 minutes is not often.
Yeah, it should be like every time.
Yeah. Oh, let's bring a palmier for the birdie.
Liberty.
So right where you're waiting for the shuttle at like across from Pride Hall, there's like a little like caged in like I don't know electric.
All right, so we're gonna get that thing going, Tim.
There's a pigeon like.
We'll get it up there. They'll be able
I have
to
no idea how to get the
inject the
pigeon out.
monkeys. Inject the monkeys.
Yeah. Very like.
Yeah, I thought that was just the second time already. Trying.
Yeah, this is the second time because the vial broke the last time. That was ridiculous. We think they dropped it. There's no way. There's no way.
Draconian, no less.
Oh my god. We made an imaging and shipped it to Portland, and it showed up. The file was broken, and you couldn't. It was all over the inside of the box.
Oh.
Yeah, they won't be able to send that back for a month. They gotta wait 30 days. Thank goodness it's not a really long lived. But yeah, it was so stupid. I'm like,
Charles are doing.
how many things? We've sent tons of stuff up there. We've sent all kinds of things.
Charles's.
They're for 3D. They use a thicker wall vial, so if that happens, it won't break. But ours, because we have to put more volume in it, because they're doing microliters, right? We're doing milliliters, so we have to have a bigger vial, and we're using your box confined to a space. Right. Okay, thank you.
Thanks again.
Very nice meeting you.
You know, we're confined to a particular space.
Sorry to
So we have to find a vial that fits in there. And the one we have is a little bit thinner walled. It's not thin, but it's thin enough. And so we figured that if you know what had it, we think it drops. Or thrown it off. And ask John for the box. I don't think we ever saw it or got it. Just to see if like a corner was thin or something like that. But we figured it had to be a good shot. So there's enough space in there that things could have, you know, if it dropped hard enough, then it could have, you know, that shot.
Actually, mine was just.
I don't know.
I think it's just
invite you and Brian like
Which is what we've done now. Padding on top of the bottom and the sides, so that it won't move in there.
Yeah, that makes sense. Oh, Brian got an invite too.
We don't know if it gets dropped. Shock.
Okay, I'll take your picture.
Right, even because
Man,
it's confined in the lead pig. You know, it's in the pig.
I'm gonna stand behind them with your CIDMI t-shirt.
Right.
Forward.
And you want to go in the middle?
Well, fingers crossed.
They'll pick it up. Yeah.
And we'll arrive.
Oh, it's actually.
Be really interesting to see though. Now fully suppressed.
Well, I'm glad that we, I'm glad that we have the extra day because we get this on Tuesday. So.
Do you want to get in the photo?
We might.
Yes, Chef.
Well, we all can't have a photo.
We all can't go on the photo. Oh, we could. Hold on. Let me see.
I'll
do one of
them. You can do the selfie with us behind.
Right. I'll try.
You are good at the selfies because you know, like whenever I'm trying to get a group family photo and we were
hiking, you've got the longest arm.
Cass is just like, oh, because I'll try the selfie and he's like that. And so, like, my kids are really good at getting stuff because they just know how to do it.
Yeah. Get that. Yeah. They got a lot of practice.
Oh, you're doing it with a selfie here?
Oh no,
and then panorama mode.
The phone
matches the water bottle.
Yeah, it's so great.
Is that point by
Have you seen his
Wait.
desk? It's all.
Are you standing behind?
Oh yeah, so
Okay, we all have to.
I think once you coordinated the water bottle, that's.
There you go.
Yeah, and then wait.
And then you do it.
So Amanda was a chemist undergraduate.
Let me light it up. Oh my god.
So is this going on there? Okay.
Oh, you can't flip it around.
The camera isn't wide. It's not. Oh, you have.
Oh, you can't flip it around.
Should I take the pizza plate away?
Yeah.
And are we in it? Is the
That's
question.
okay. So Tim's head is not.
I'll just sit down because I'm too big. There we go.
And I'm too big.
I can't do Val's head. You need to move between there.
Yeah.
And then I'm gonna sit here.
Well, that's fine because
So you guys will need to you need to like squat slightly higher. Like get at Val's height. No, okay. We're gonna try it.
That would take an enormous amount of leg strength.
You should have to lower the.
Like the
Now are you gonna be able to get? Yeah. See if we can lower that chair now.
Hurry.
5.
It's gonna work. It's gonna work. Okay. Well, if you can see the camera, it can see.
Okay.
Yeah.
Let's do it.
Didn't work.
I was gonna go underneath to get it. I don't need to do that.
Did it do it?
Did it work?
I don't know. Maybe it be. Oh my God.
It worked. All right.
Yay.
Hey, looks pretty good. All right. We're all in there.
Can you send it to us?
Yes.
Thank you, thank you, thank you.
How many degrees does it take one?
Yeah. This is mine, right?
Yes. Yes.
Have the last piece of
No,
pizza.
one slice of pizza.
One
now.
last piece of pizza.
Should we bring it for Brian?
Brian.
Poor Brian.
Poor Brian. Where's Brian?
He's finishing something up for Peter.
We could just.
Oh, the senator study. Yeah.
We could just.
Oh, yes.
Yeah.
I'm supposed to be going to Francis to get the swap, but I was wondering if you wanted that. Stool swabs? Oh, not the swabs, the stool RNA.
The butt one?
Brian, please.
You know, I'm kind of a hoarder when it comes to lab samples, right? I'm gonna say yes, because
Order.
they've been trying to get me to clean out the freezers, the minus 80s for, and you can just see it, oh, okay.
And you're adding more to
Remember,
it.
remember when we tried to have the thread of if you don't do it, you have to donate to the Republican Party.
Oh, right.
So you would absolutely do it.
Except Memorial Fund, yeah.
Oh, that's funny.
I will,
Well, thank you, Val, for setting this up.
Yes, yes,
Let's
yes.
keep
Let's
it.
like that.
We'll,
it's, I mean, if today doesn't work, like, it's, yeah.
No, it works.
It works.
I just didn't want to
got
go over
everything
there.
else.
I know.
You know that.
Yeah, but it kind of doesn't.
We could ask him
They're gonna
to,
fall. We should bring them down maybe.
we should probably get it back.
What?
Dude, you look like you're in a mugshot.
Well, it's like I didn't know what it was gonna go. You can Photoshop me later. I'm sure AI. Oh my God, I do look like it's a mugshot.
I'm gonna make this
What
like
the hell?
some kind of
Do I
black.
normally look like that in
No.
pictures? No? Like, is that how I normally look? Because I look pretty.
You probably no, you look like not really yourself.
That's like serial killer.
No.
Look, that's not cool. What was I doing? Normally I'm smiling and oh man. Let's see.
Okay, are you coming to Pride Hall with us, Amanda? Or are you staying here? Okay.
Going for Natchez.
Oh yeah.
Do you have a car?
No.
No.
We're shuttling.
You're shuttling. I have a car parked in that right where the rec center is. Because I think I'm gonna take back some of this stuff.
Oh yeah.
If people want, I can take a maximum. Well, like 4 would be a squeeze, but with Val, we could probably do it because
Yeah, why don't we do that?
if you want to do that, if you
Sounds good. We can
1, 2, 3, 4, 5. It's a small. You see in the car, it's not very large, but you could squeeze. I mean,
it
holds 5.
Only half
She's twice the person.
Twice the person, half the size.
But someone will have to sit behind me though. Is the problem? Okay, because I have to push that seat like all the way back, and there's like this much space. But we can probably okay. All right.
Just put the plate on that.
Well, we put on the seat now.
I'm not gonna lift it.
No, I
And we'll be
We'll take everything back. And you want to throw it. Well, how did you get all this stuff over here on your bike? I know. But you packed the car and changed stuff. And then this morning.
No way.
I got in the car.
She should get in the car. And she just put the bike on the car?
No, you guys walked in here. Because I
What type of car is
They
it?
picked it up. Oh, I read it. Oh, wow. They took it up. Then I went.
Do you want to take?
That's why you were supposed to. You came over here. I was supposed to go. But it was late.
Yeah.
Like, you know, like this one. Like this. Look at this.
Yeah.
Yeah.
These little conferences.
Sort of like a smaller one.
Yeah.
But it's a little.
So 105, the one in the corner,
It's like a little independent. This one works though. Okay, because look at this time right now. There's nothing. There's nobody in the meeting. No, but they were all.
Oh, did you guys get it soon?
oh yeah, I don't.
I can take a
May as
little.
well. It's okay. And it's building upper body strength yet, so.
I just have to grab my time.
That's mine.
That's yours.
And
Water? Anybody
water, is that Mandy's water?
Oh, that's your.
I will get it for you, so you don't have to have it on your bike.
Oh, no, I'm good.
You sure?
Yeah, I just have my bike bag.
Okay, drive safe.
Yep, we will see you guys over there.
Yep.
Really, okay, that's one done.
Everything, oh, this is I'll get the water out. Okay, this looks good, okay.
Yep, we got everything, got your bags, we're good.
Thanks.
Yeah, just look at that stuff for, so the one thing that I need your eyeballs on is that stuff for the agreement, the data sharing
The
agreement.
data sharing.
So I'll get that. I sent it off to, you'll love this, I sent it off to Sam. And I said, all right,